So my name is Natasha On, and I'm the second year fellow at University of Chicago, and I'll be serving as the moderator today. Welcome to Online with Experts series. Today's presenter is Dr. Johannah Scheuer, who will be speaking to us about antenatal consultation and highlighting 10 guiding principles. Before getting started, I just want to remind everyone to keep their mics muted during this talk. So Dr. Joyer is an assistant professor at the University of Minnesota. She completed medical school, pediatric residency, and NICU fellowship, all at the University of Minnesota, and now serves as the fellowship director for the program. We all look forward to this talk, and I'm just going to hand over the mic to you.
Wonderful. Thank you, Natasha and Deirdre, for hosting me for this talk today. We'll go ahead and get started. Thank you for the introduction. And before I start talking, I would love to, either by putting it in the chat or quickly coming on video and showing what year of fellows do we have here today.
Hey, I'm Rahul Joseph. I'm a second-year fellow at the University of Kentucky.
For several first and second year fellows, awesome. Another first year, thank you all for sharing. I don't have an exact definition of what complex antenatal consultations are, but I'm curious, before talking about complex ones, how much experience people feel like they've had doing consultations, and no specific number, but do you feel like you have done not much, a little, a lot, a ton? Would love to hear a little bit of that too.
Hi, I'm Jessica. I'm one of the third year fellows at ECU. I feel like we get a lot of great inpatient consultations. A lot of our attendings do the outpatient type of stuff, but from an inpatient, I feel like we get a really good experience.
Great, thanks for sharing. I'm getting some messages too that people have done a fair amount in later gestational ages, fewer consultations, and the kind of limits of viability, early gestations. Thanks for sharing. And if you think about what you would consider more complex consultations, and probably that earlier gestational age is part of that for sure. Is that something you feel like you have less experience in? And I'm getting that many people have done a lot inpatient, but less in the outpatient setting. Does that ring true for others?
I know at the University of Chicago, speaking as a fellow there, we definitely get a lot more time inpatient. And I agree that the more difficult consultations are probably the ones that are around that peri-viable period. And also because it's inpatient, if they're in labor or depending on the maternal status, she's in a lot of pain, or if things are moving really quickly, I think that would be a more complex consult.
Yeah, so the timing can make it more complex, and what's going on with the mom. Okay, thanks. So a couple disclaimers as I go ahead and get started. I am from the University of Minnesota. That's our Masonic Children's Hospital there. The NICU is actually in the brick building over here. Minnesota, I always feel a little defensive about Minnesota. It's not that cold. We have this new logo for our Department of Pediatrics. But beyond that, and you can tell I'm biased toward Minnesota, hearing that I have done much of my training here and now work here. Beyond that, I have not done my own scholarship in antenatal consultation. It's a clinical area of interest. I am one of the neonatologists in my group who does outpatient antenatal consultation. Not all of us do that. And I specifically run our perinatal palliative care program and do consultations in that setting. So I have accrued these ideas and resources over time, and there are many experts, I'm sure some among faculty you work with, who have done scholarship in the area of antenatal consultation. I have not. I have done a lot of work in pediatric end-of-life care skills and how to help trainees develop those skills and educational models that work to develop those skills. And so there's definitely some overlap there. And the other thing to acknowledge and include in my so-called disclaimers is in my end-of-life care skills work, it's very important. I work with bereaved parents who have had the death of a baby or a child, and their perspective is so important in informing the work that we do in that education. I don't have a parent partner sitting next to me today with this talk, but want to acknowledge that parent and family perspectives are extremely important in this work, and you'll see as I share some resources that a lot of the work is informed by that. And
Oh, I don't know if this is the same for everyone else, but I can't hear you anymore.
can you hear me now?
Yes, thank you.
Sorry, some headphones dropped on the floor and tried to switch to that audio. So anyway, the family perspective is so important in general in the work that we do, and not just trying to center families in the work we do, but integrate them and promote family integrated care. So just want to acknowledge that no one is sitting next to me today, but I really appreciate that perspective, and much of the scholarship in this area has parents' perspectives is being integral. So we'll go on and get started with the 10 principles that I think are important to consider. I'm not going to give you a cookbook method of how to do every single antenatal consultation, but hopefully some ideas of things to consider and tools that you can use as you develop your own ways to do these more complex consultations. And I would say it's principles that ring true for less complex, so-called more simple too, as well. So the first is really finding mentors and role models, and I don't have to tell trainees that the importance of who you're working with and noticing what they're doing, but to mention that it's not just physicians. Some of my best role models and mentors in this work are non-physicians, and especially many skills I've developed over time are informed by one of my close social work colleagues. Think about, lots of times we think about, oh, mentors have to be someone older and more experienced than me, but I also think peers are important as you work with one another. Think about that. And then also think of non-medical sources and things that are out there about difficult communication. It doesn't just have to be in medicine. One important source for me over time is a woman, Brene Brown. She's a sociologist. Many of you may be familiar with some of her work and books, and she has podcasts. This book, Dare to Lead, has been an important piece of professional development for me, and there's some overlap in in its application to antenatal consultation. And in particular to this talk, I really love how Brené Brown talks about empathy. And I think empathy is not a foreign concept to those of us in medicine. We hear about it a lot. We seek to be empathic. But some of you maybe haven't thought about it for a while and thought about what does it really mean to be empathetic. And so I thought it would be interesting for us to just watch this short video about empathy. And I'm going to need to do a share switch. So just a second here. Can you hear? Can someone tell me if they can hear?
The volume isn't that good.
And why is it?
Oh, there we go.
Empathy. Empathy fuels connection. Sympathy drives disconnection. Empathy, it's very interesting. Teresa Wiseman is a nursing scholar who studied professions, very diverse professions where empathy is relevant, and came up with 4 qualities of empathy. Perspective taking, the ability to take the perspective of another person or recognize their perspective as their truth. Staying out of judgment, not easy when you enjoy it as much as most of us do. Recognizing emotion in other people and then communicating that. Empathy is feeling with people. And to me, I always think of empathy as this kind of sacred space when someone's kind of in a deep hole and they shout out from the bottom and they say, I'm stuck, it's dark, I'm overwhelmed. And then we look and we say, hey, you climb down. I know what it's like down here and you're not alone. Sympathy is, ooh, it's bad, no, you want a sandwich? Empathy is a choice, and it's a vulnerable choice, because in order to connect with you, I have to connect with something in myself that knows that feeling. Rarely, if ever, does an empathic response begin with at least. Yeah. And we do it all the time, because you know what? Someone just shared something with us that's incredibly painful, and we're trying to silver lining it. I don't think that's a verb, but I'm using it as one. We're trying to put the silver lining around it. So I had a miscarriage. Oh, at least you know you can get pregnant. I think my marriage is falling apart. At least you have a marriage. John's getting kicked out of school. At least Sarah is an A student. But one of the things we do sometimes in the face of very difficult conversations is we try to make things better. If I share something with you that's very difficult, I'd rather you say, I don't even know what to say right now. I'm just so glad you told me. Because the truth is, rarely can a response make something better. What makes something better is connection.
Okay, I hope that sparked some thoughts for at least some of you. The second guiding principle is really thinking about words and phrases you're using. And that doesn't mean there's a perfect way to word things or phrase things, but to find what works for you, to try new things when that's appropriate. And just a few examples, especially as I think of some of the perinatal palliative care consultation I do, the difference of lethal versus life limiting is typically a better phrase. Not talking about withdrawing care, but providing care primarily focused on a baby's comfort. Not talking about aggressive medical interventions, but life-sustaining treatments. Thinking about the replacing but with a period or an and I think that's somewhat related to the Brené Brown video of the at least. I think it can sometimes, when we do but, it can invalidate what we said before that. So thinking about that, and that goes beyond antenatal consultation too. It's a good life communication thing to consider. And then really being aware of jargon, and there's tons of jargon research, and I think there's even more jargon research. For an example, some researchers from my institution interviewed folks who actually were predominantly college educated, if not further, and asked about all different specialties in medicine, and almost no one knew what a neonatologist was. They asked about different levels of training, like student, intern, senior resident, attending, and the majority of those several hundred people thought a senior resident was the highest level of experience and expertise on a team. So lots about jargon, but always thinking about how we're explaining things and talking about things in a way that families can understand. There are great resources related to how you might phrase things, and the organization of a discussion. Vital Talk is one. It's an evidence-based education resource, and they do lots of different trainings, and then their website has a ton of resources and free materials that have some helpful mnemonics and can be a good kind of guidepost, especially as you're developing kind of your way of doing these more difficult conversations. It's not pediatric or neonatology specific, but I think, again, is good for guideposts. And for example, discussing prognosis with families, they have this ADAPT mnemonic where you want to be asking what a patient knows and what they want to know more about, discovering what info about the future would be useful for the patient, always anticipating that there can be some ambivalence for the patient and family, providing the information in the form that the patient wants, whether that's talking more, handouts, time, etc., and then tracking on emotion. And I would say great handouts, and a lot of it doesn't mean that you're going from A to D to A to P to T during a meeting with a family, but that these are things you're thinking about and are being woven throughout an encounter with a family. So just kind of think about what is in your back pocket of phrases you like to use. What have you noticed people you work with, phrases that you hear them say again and again? And I think sometimes I'll think of mentors who always say a certain thing and remind myself, well, they always say it, but to all these different families who are hearing it for, one and only time. Over time, just to share a few things that I am always making sure in my back pocket, the power of saying I'm sorry, and I'm sorry you're going through this. The power of allowing silence after you've said something, after they've said something, letting yourself get uncomfortable. If a family is uncomfortable with silence, they will break it. That being said, it's almost always doctors who get uncomfortable before families, and there's research showing that doctors tend to break silence between 6 and 11 seconds. So think about that sometime, and think about how much silence you allow, and maybe consider letting the family break the silence at some point. A few phrases I tend to use in my consultations: we're here to be part of your team on this journey with you. So really kind of joining the family. I'm meeting them at a journey they are already on, and I am there to join them on that and be part of that team. Talking about things you hope are true or hope will happen or hope the family and baby will experience. And again, using and, not but, and things you're worried about. And I think that's a way to share both and stay honest and engage with the family. The next thing I always think about is what preparation I'm doing before seeing a consultation. And I think certainly, especially on the inpatient side, we may not have a ton of time to prepare. And a lot of this might be dynamic in the moment. But in the outpatient complex antenatal consultations, I really try and set aside some time to read the patient's chart, the mother's chart before the day of. And that helps me know, okay, what referring providers do I need to talk about? And at a minimum, that's going to be maternal fetal medicine, who has asked me to see the patient. But it may also be consultants. The family has already seen a pediatric surgeon when there's congenital diaphragmatic hernia. So for me to hear both from the surgeon and then when I meet the family, what they have talked about, or maybe they haven't met with the family yet. So hear what they're thinking and may want to address when they do meet with the family. So yeah, thinking about what other consultants are part of the team and who you want to be on the same page with, or at least understand their perspective before you go into the consultation. And I do think it's important to be able to pick up the phone and talk to these people. You can get a lot of information reading the chart, but there's nothing like actually talking to someone. And then making plans with your team. Who is going into the room with you? Who would you like to have there with you? We do most of our antenatal consultations with one of our maternal child health social workers, and that's really nice to have them be on the same page. We do some of our antenatal consultation. I wish we did more, both in the in and outpatient settings with maternal fetal medicine together, because inevitably there is some question related to the obstetric care that I am unable to answer. And not that it's bad, I'm comfortable saying I'm not sure about that. We need to talk to the OB team, but I think it can help to be there and be discussing those things at the same time. And then once you're all prepared, also be ready to be flexible, because sometimes what's in the chart, what you talk to the consultants with on the phone, is not where the family's at that day, and they need something totally different than what you thought you were going to be having for a conversation that day. So thinking about the actual kind of anatomy or going through the consult, again, I don't have a cookbook method for you, but based on what some folks have studied, and one article that Dr. Lantos, who is an ethicist and works in the NICU, did a review of kind of multiple studies of antenatal consultation and offered kind of what are we even trying to do for a consult? What's the purpose? And he looked at 19 different published articles, and not surprisingly, they found that parents want information about the anticipated chances of survival and about their baby's long-term prognosis. So I think that's not surprising. But more surprisingly, unlike many doctors, parents didn't usually think of these conversations as one where they were deciding if they should provide neonatal intensive care unit care and life support. Those consultations, families' perception that that's what was going on in the consultation was much more few and far between than what the doctors thought. But they want the information about their baby's chances of survival and long-term prognosis to help them prepare to participate in the care of their babies and know what that might look like. They really don't want information to be only negatively framed. That doesn't mean not sharing your worries with them, but they, time and again, across these multiple studies, didn't think that they needed to be reminded over and over about the potential for neurodevelopmental disability. Folks who emphasize that information more than families wanted, they felt like they didn't trust physicians as much in that setting. The parents want providers to be sensitive, compassionate, and attentive to their goals. And so consider the goal of talking less and listening more. And again, across the studies, parents are willing and want to share their hopes, fears, values, and preferences, but sometimes feel kind of overshadowed and unable to do that if they're not given the time and opportunity to do so. And often they are able to reveal what they want to learn and kind of direct the consultation toward what they want to know, what they need to know. And doctors who are able to do that really active listening can individualize the discussion and respond to what that family needs in the moment. And that's really, I think, what can enable kind of family integrated approach to antenatal consultation. So thinking about eliciting questions and understanding, listening to their narratives, who's important in their life, how do they make decisions, and working to build a relationship, even in that short setting, and finding out what information they're looking for and what you're going to give them. And I often start by asking families to kind of share where they are on the journey and their kind of version of it. And I acknowledge that I've looked at stuff in the electronic medical record. Here's who I've talked to, but how would you tell me about your journey so far? And that to me can be very telling. Some people, they like essentially say everything I've read in the chart, and they might have tons of medical language. They might be using more jargon than I was planning to use in the consultation. And other families, they're like, I'm here today to find out when I'll be able to visit my baby in the NICU. Or I'm here to find out, will you do a circumcision in the NICU? So really, listening to them and responding to their needs. And then it's hard to even think of how do we encompass what happens on the NICU. I have tons of information I can give them, but what's important for them to learn that day to help them plan what it's going to be like. So I would say again, so those are some ideas to keep in mind, and I think are encompassed in this ADAPT framework that I showed you that Vital Talk has. A little bit more about what parents want. This is from that review article by Dr. Lantos. And that article has kind of a nice list, and the article goes into it more. And it is the things I kind of already said, that it's not about whether or not to provide life-sustaining interventions. They don't want it exclusively negatively framed. The repeated reminders, and those things can lead to distrust. What they do want is how to help prepare to care for their baby, chance of survival, that should say long-term prognosis, sensitivity, honesty, compassion, and hope that's attentive to their goals and helps build trust. And really, we are starting to build trust with the NICU we're kind of the face and voice of the NICU as they get ready for whatever that journey is going to be in the NICU. Here's another paper more specific to extreme prematurity. It was, again, another systematic review of multiple studies of parent communication needs, summarized here, but a great resource to look over. They want compassion and trust, individualized, honest information, a multidisciplinary team approach. So again, if it is just use the doctor going in there, also thinking about would it be helpful if a chaplain follows up with them? What might a social worker help provide and follow up? Supportive documentation, not meaning the note you write after, but are there videos, are there pamphlets, and what that might look like for the family. And then they want time for reflection. If you are asking them to think about some different choices and options of care, it's not necessarily going to come moments after sharing information with them and having that conversation that day. This is my opinion, is that percentages are overrated in our conversations with families. Some families really want a percentage, and I will occasionally, if that's something that's really important to a family, I will share that. I don't need to keep anything away from them. But still, even when I do share actual percentages, there's a real acknowledgement that their baby isn't a percentage. Either they will survive or they won't survive. They will have this outcome or they won't. And so I think percentages do help some families, but not something that I share every single time. This is to show some other great resources that are out there related to some outcomes. And I do think that percentages can be helpful for me to kind of know about framing the particular situation and how hopeful I am about a certain outcome versus how worried I am about another outcome. So Society for Maternal Fetal Medicine has some great resources. Many of you may be familiar with the observed to expected LHR in congenital diaphragmatic hernia. And this is kind of, this isn't a talk about the O to E LHR, but to kind of point out that this puts patients in a category, and the filled in bars have to do with when there is liver herniation, the open bars there's not. But again, this is putting patients into a category of a more severe prognosis with a lower survival rate, medium and mild prognosis with a quite high survival rate. But even look at this, it's not even big numbers of patients. So again, I might use this to frame my hope versus worry, but I'm probably not using these percentages. But I do think they're important for people to be familiar with. I don't want you to get the idea that Dr. Scheuer said don't care about percentages of outcomes. And then newer outcomes percentages to remind you about that MRI, total lung volume, and contralateral lung volume in the setting of congenital diaphragmatic hernia is another kind of survival help with prognostic cutoffs. The NICHD has the extremely preterm birth outcomes tool. Some people are quite attached and really like knowing this percentage. I think some people share this with families most or all of the time. It's not something I share with families, and I encourage you also to find out at your own program what your own outcomes are in that institution related to extremely preterm birth. and know that these statistics are put together with lots of hospitals that have different practices and what they do in terms of maternal care, and even giving steroids or magnesium when there's threatened preterm birth, or doing that less often, at what gestational age your institution even offers resuscitation. So anyway, it can be useful for you to get a broad sense of what outcomes may be, and know that extremely preterm birth outcomes are related to these factors: gestational age, birth weight, infant sex, singleton or multiple birth, and whether or not antenatal steroids mom has received antenatal steroids. But again, not something that I directly share with families, and encourage you to also know your institution's numbers. Trisomy 13 and 18, literature and outcomes is another thing to think about. And this is a paper talking about which patients had better and worse outcomes when heart surgery was done for patients with trisomy 13 or 18, and kind of thinking about for whom with trisomy 13 or 18, which intervention should be offered. And there is some predictive ability based on if infants with trisomy 13 or 18 have congenital heart disease, their need for a gastrostomy tube, their need for TPN, their need for positive pressure ventilation on their overall survival. So those things are out there and probably inform how you talk to parents and what interventions your hospital will and will not kind of work with families to provide. But also know that there's a lot related to what quality of life families perceive for their infants with trisomy 13 and 18. So again, a reminder of all the things that may be part of what you're considering when you do these more complex consultations. The sixth principle is the very much important thought of hope, and I've already said that a little bit. I think it's really important that we give families the permission to hope, and I think it's easy for us to perceive that, oh, this family has a hope that does not match with what we think is going to be possible for their baby. They must not get it. They must be in denial. And my experience over time, and some of the very experienced social workers I work with, would say that that's not true for families. They can hold both to be true. They can have hope and completely understand and know that their baby has a low chance of survival, but they can still hope for the miracle and have both be true, which I think is harder for many of us as doctors to believe to be true. But parents aren't seeking anything certain, and they can hold both. And I think it's important for us to allow that and not take that away. The importance of context for a family. So broadly, context is kind of who, what, where, when, why, how, and just thinking about really cultural considerations and how that is part of people's belief systems, their spirituality, who's in their family, who the community they live in, where they work, etc. All of that, and just really acknowledging that kind of where we're seeing them in the clinic setting. And luckily we can at least have family members in the clinics now. There's a period of time where it was very difficult to mostly be doing consultation with the pregnant person themselves and maybe someone else on a video. But we're just seeing them in one little context, trying to understand what their larger context of their life is, really as part of what matters and how they get their information and what information they even want and how they make decisions. I think in the complex consultations that anytime you can have an in-person interpreter, that's super important. I find that much more effective than our phone and video interpreters. And then also know that there are social media platforms for different disease processes, different support groups, and that's great. That is an important piece of context for many families. And so even exploring, like, what have you heard about this? Who have you connected with, or have you connected with other families whose babies may be affected by the same thing as you? Just one example, there's tons of examples, is SOF, the Society for Trisomies, and that's mainly trisomy 13 and 18. Principle 8 is to reflect. I think it's really important to be reflective and open. Ask those who you're working with how they think it went. Think yourself about how it went. And it's not just about you trying to do a good job. I think it's also important to believe you did your best in that moment. And maybe you would do something different in the future. But there's also so many other factors going on. And I may have kind of done the same thing in 2 different consultations and appropriately responded to the families, but what they walked away with after that has much more to do about them and where they're at than necessarily how I did. As they're on this quite traumatic journey. Think about where you might learn about this in other arenas. There's interesting work about using doing improv in a medical setting, including specifically antenatal consultation. There's some of that as an educational modality, simulation, different professional developmental opportunities, that might be at meetings you go to or other things. So kind of reflect and grow. And then I think it's so important to stay curious and follow up, learn, was this helpful for the family? And then what did happen to the baby after they were born? And prepare to be humbled. I have certainly had cases where we've had families ask for life-sustaining interventions in a setting where we were quite certain that the chance of survival was really low, and a baby has been able to survive with life-sustaining treatments. And I've had things in the other direction where, say it's a congenital diaphragmatic hernia that we thought was going to be in that mild category, and a more standard, not complicated course, and the baby has required going on ECMO and has not survived. So stay curious and prepare to be humbled. I have to just throw a shout out to Ted Lasso, and he has a so-called rule of living of be curious but not judgmental, and but it actually may be originally a Walt Whitman quote. Finally, the 10th principle I say is don't throw anyone under the bus. Again, everyone is doing their best. Try and meet everyone where they are. trust the process and know that ultimately it's about the family. It's not about you. And, I think sometimes I'll be seeing a patient in consultation who has been seen somewhere else before and wants a second opinion. And earlier in my career, I may have been more judgmental and thought like, oh, they must not have gotten good information at the other place, or the other person didn't say anything helpful. But really, that is rarely the case. It's what the family needs. And I've had families, after I've met with them, then they seek an opinion somewhere else. And I think we see this a lot too after a patient is born, and it's easy to say like, wow, the family was very blindsided by this. Didn't anyone talk to them about this before birth? Or they must have not, said the true prognosis. And I think believe in whoever is doing that process beforehand. And again, recognize that what a family can remember from that is going to be different on any given day, and how they interpret it and all of those things. So I think trusting that the process is going well, and that you're doing your best is really important. So we got through the 10 principles. To review, it was we talked about finding mentors and role models, phrases and words matter, how to prepare going into a consultation, thinking about kind of the anatomy and how you might want that consult to flow. My belief that percentages are overrated, but are important to know about as a fellow and neonatologist, but overrated in being shared with the families if that's not something they specifically want. The importance of hope, the importance of context, reflecting after an encounter, staying curious and following up, and then not throwing anyone under the bus. We have time for your questions or any cases.
Great. Thank you so much, Dr. Schleyer, for addressing this important topic. Before we go into Q&A, I just wanted to remind everyone to complete the evaluation. I just put the link in the chat box. As for the actual Q&A,
I can put up the QR code too.
Yes, perfect. And then for the Q&A, everyone is encouraged to either unmute and ask the question yourself, or if you type it in the chat box, I can read the question out loud to the group. Do we have any questions or cases, I think, to get us started?
Yeah, I have one question. So I guess in the scenario of a baby that you think is really struggling and really in pain, how do you deal with families in that regard, in terms of, I guess, wanting to support them, but also knowing that this, or feeling like this baby is in pain? How do you deal with that, like morally, and what do you think we should do about that?
Oh yeah, simple question to finish the afternoon. Yeah, that comes up for everyone, I think. And yeah, and the moral distress that can go along with that for team members. Thank you for bringing that up. I still think it's important. It's not the family's directing and deciding what care is, but us being responsive to, what else do they need to help their baby transition to stopping life-sustaining treatments and focusing mainly on comfort. And some families will say like, well, I thought you've been giving pain medicines this whole time. So I think it's also making sure that people don't think it's like comfort care or life-sustaining treatments, that we hopefully are always helping with the baby's pain and comfort, but starting to cut back on the life-sustaining treatments. And while I don't think we should continue doing anything which some might call futile, but though that term is some people don't find that to be a completely useful term. So we shouldn't keep doing things for months or years that aren't going to lead to a different outcome. But for a family to have time to get to the place where it's the story that they live with forever, whether that be some extra hours or a couple days to help them get to that place, I think is really important sometimes. And it's nothing black and white. It's a very gray area. But I think in our role as neonatologists, sometimes we need to help our team members understand that we're helping families get to a place of transitioning to comfort care and the story that they live with for their whole lives. And while it's hard for us and traumatic, and secondary trauma is a huge deal in our profession, of course, at the end of the day, we go home and we haven't had our baby die at that time. And so really having them be integrated in how that may happen is important. So I don't know if those are some thoughts to think about. It's not a true answer, Kylie, but yeah.
Thank you. I was just kind of looking for that moral distress and kind of where we should sort of focus, and it sounds like maybe more supporting families to get to that point is beneficial.
Yeah.
I have a question in the chat. It says, do you have any advice about how to introduce a consult with an approach of not having to make a decision when you have been asked to have the parents make a decision as a result of your often brief conversation?
So that's probably in the setting of kind of preterm labor or a decision about delivery in the upcoming time. And I think there are certain times where we very much need to help a family kind of get their goals and values out and think about if resuscitation makes sense for their baby or not in a pretty quick time. And yes, I still would encourage you to have that conversation be as long as it needs to be. And so it's rare that needs to happen in 10 minutes. It might need to happen in the next hour or two, but so still to kind of give what time you can in the situation. And those are the times where I think if there's any way that you can be with the OB team, it can be really helpful to understand together. And I think also framing that a decision to offer resuscitation and pursue resuscitation at that time does not mean it's a decision to keep doing all the interventions days or weeks later necessarily, and thinking about points in time where the decisions could change again, and different scenarios where the decision could change is important to keep in mind too. So not trying to carry the weight that it's a decision to do everything forever versus do no resuscitation, and that being the end, that there still is some gray area. Does that make sense?
I guess I have a follow-up question. So I know in your talk, you really highlighted that different parents, you kind of have to meet them where they are, and they may want different information, but also different parents receive information in different ways. So we do a lot of talking. And I was wondering if you have any advice, or if you actually use other different things like videos, or you give them information that they can read after you leave, any other tools that you use during your consultations?
Yeah, great question. And I think sometimes it's even acknowledging that they're not at the point to digest a lot of information that day, or they may tell you. And so that actually you only spending 10 to 15 minutes together like is maybe just as good a use of time as it seemed, as they don't have many questions, don't want to go there about things, and then like spilling out information for an hour. So that's one piece of it. But then having planned time that, you know, I'm going to come back in what kind of time frame. Yeah, some of the different patient advocacy and support groups, I will mention those to some people if that's the kind of thing they are interested in. We have some handouts for some disease processes that we will give them. I don't have a ton of video resources. I think some places have more and better of that than I use. But even sometimes I might go do a quick Google search and find like a different institution's video about some complex heart surgery, and then tell them about that, to look that up. Not saying like, hey, go Google this at home, but you know, I might know that a certain institution has good videos that I have done that before.
Thank you. I think we do have time for one last question if anyone has anything they've been holding on to. If not, I think thank you so much for speaking to us today and for really highlighting these 10 guiding principles that, like, I think your slideshow was really, really easy to follow. And I think all of the fellows, I can say, this is really, really helpful.
Thank you so much for having me. Thanks everyone for your participation and questions. And have a wonderful
Thank
day.
you. Sorry. I think the survey link is not working, which is odd because I just fixed it. But I'm going to put in my email address, and if you have any direct feedback, please just feel free to email me. Thanks.
Thank you.